Hello, hello. Welcome, everyone. Welcome, everyone. Please come and join us today. Hello, and welcome to this episode of Black Health Now. My name is Talisha Ramsey, and I'm the Vice President of Diversity, Equity, and Inclusion at Patients and Purpose. I want to welcome you all from across our OHG agencies. I'm very excited to have you join us today. As you all know, it's Black History Month and American Heart Month. So for this month's talk, we're going to combine these two topics. We're going to chat with our panel about the history of cardiovascular disease in this country and the Black community, the current state of it, what's contributed to disparities and continues to contribute to them, and what we can do to affect change. Before we go any further, I'd like to share with you that I'm extremely passionate about this topic. As a Black woman, I am concerned about the health of the Black community. And it's also personal for me because I know of 3 Black men who I attended college with who all have died from a heart attack or stroke in the last year. Also, many members of my family, my immediate family, which includes my mother, my brothers, and my uncle, they all suffer from some form of cardiovascular disease, whether it's hypertension or diabetes. My intent is that each and every one of us walk away with more knowledge about cardiovascular disease and what we can do as healthcare marketers to disrupt the disparities and empower the Black community to advocate for themselves. Now it's time for me to welcome our amazing panelists of healthcare professionals. I'd like for them to please introduce themselves and describe their work. So we'll start from my view, we'll start with Ms. Malika. Would you please introduce yourself and describe your work?
Hello, everybody, and thank you, Talisha, for inviting me to participate in this panel. I'd like to thank also my other panelists, Dr. Pacoridi and Nurse McHale. Thank you very much for joining me today. I think between the 3 of us, we could bring a lot to the table. My name is Dr. Malika Feely. I do work in Englewood. I'm a nurse practitioner, and I do work in the cardiovascular lab where we deal with cardiovascular interventions, meaning catheterizations, and in terms of the electrophysiology and latest with a lot of structural procedures in this clinical setting. And as I said, we have a lot of patient population. However, as being as an African American, it is my honor to be here and to be with you guys on this panel. Thank you.
Thank you. Next, we'll have Dion.
Hi, everyone. My name is Dion McHale, and thank you, Talisha, for inviting me. And Dr. Filoso, it's nice seeing you. I hear a lot about you. And Malika, of course, I know you from a long time ago. Well, there's a lot I am doing. I am a nurse. I'm still at the bedside, and I've been at the bedside for 29 years, but I've been a registered nurse for 19 years. I'm also a nursing instructor at a community-based school and 2 schools, Rockland Community College and Dominican College. And I'm also a nurse practitioner, and I do in-home assessment where I do get intimate with the patients. I get to see how they live, and I get to mingle with them, and that is fun. So I'm happy. I want to learn. I'm happy that everyone is joining us. So I just want to give a lot to the community.
Thank you. Thank you so much. And then last but not least, Dr. Felicia Pacoridi.
Hello, everyone. Thank you for the introduction. First of all, just wanted to thank our host for inviting such an esteemed panelist. I am honored to share the stage with 3 bright and esteemed women who not only have experienced what life is like as a cardiovascular specialist, but also as an advocate for your friends and your family members who have suffered from this disease that is mainly preventable. I'm an interventional cardiologist here in Cleveland, Mississippi. Originally born in Nigeria and Africa, but grew up in New Jersey, North Jersey, right next to where Dr. Malik is, Teaneck, New Jersey. I did all my training up between New Jersey and New York. And right after fellowship, I came down south, where Mississippi has 40% African-American population, to start a practice that is super focused on limb salvage and amputation prevention. We have made that a priority, and it's become both a local, regional, and national basically example of what we look for in terms of an excellence when it comes to amputation prevention care. I look forward to talking more about that later, but honored to share the stage and look forward to informing, to transforming our viewership.
Yes, that's exactly what we would like to do. We need to transform with something you just said was really keen to me. It's all preventable. And that's something that I want to learn today, and what we can do as healthcare marketers to educate people, because I think it starts there. But before we go into education, let's talk about what is the current state of cardiovascular disease among Black Americans.
Well, I can start. Please tell me when to stop.
Yeah.
March 1966, Dr. Martin Luther King Jr. made a statement in Chicago while giving a speech that said, of all forms of inequality, injustice in healthcare is the most unjust, and it's basically it's just the most unjust of all care, because it results in early death. And so this injustice that we're talking about was also highlighted in an IOM, Institute of Medicine report in 2002 that mentioned that unequal treatment exists, particularly in minority groups. So we're talking about Black Americans, we're talking about our Hispanic patient population, Native American patient population. And so unequal treatment leads to worse outcomes in this country. It also leads to unacceptable, preventable deaths. So I'm just going to keep that at the current state of affairs, because things haven't changed since 1966 to 2002, when that report came out, and to now, in terms of look at the mortality rates of our colleagues and our friends and our family members. As you mentioned earlier, you lost two friends this past year. And look at the life expectancy, look at the mortality gap between our Black and white counterparts. And let's see where that has shifted in 20 years, for instance. I'm happy to tell you that although we've made some progress in certain groups, demographics that are mainly white, when it comes to cardiovascular mortality, we've seen improvement, we've seen a decrease in their gaps. Unfortunately, we haven't seen little improvement when it comes to the Black Americans, the Hispanic or Latinx communities, and also the Native Americans. But that's where we stand today. Wow,
that's actually pretty sad to hear that there's been slight improvement, but we're still the same in the Black community. Dr. Malika, would you like to add on to this? Is there anything that you would add to about the current state of cardiovascular disease among Black Americans?
I do agree with Dr. Fakorede of what he's saying. And I mean, when you look even at the recent data from the US Department of Health, Human and Services, heart disease still remains the leading cause in the United States of America. And we as African Americans tend to have 30% more to die of heart disease. And 40% of the adults are likely to have high blood pressure. Sadly enough, as it is treatable, unlikely, the 40% that is demonstrated here don't have their blood pressure under control.
Wow. Yeah, and as I mentioned in my intro, most of my immediate family members all suffer from hypertension. All of them take some form of blood pressure medication, and I am like the only one that doesn't, and I try everything to maintain that, but I also see my family and friends work to maintain it as well, but there's always still a struggle. Nurse Dion, would you like to add anything further about this topic?
Yes, I did a little research, and my research came from an organization called the Heart Foundation. And it says here, death from heart disease are higher in Black American than in white American and other ethnic groups. And heart disease develop at a younger age in African American. And when I look at that, I look at our 20-year-olds. Just a few minutes ago, before I came on panel, my 20-year-old friend, she had hypertension, didn't want to do anything about it, and now she's went into kidney failure, and now she had a kidney transplant. So I'm looking at the 20-year-old and saying to myself, that was something that I could have helped with. I'm just finding out when it already gone a certain way. So I'm a little bit like, feeling a certain way, like, when you have health issues, why can't people talk about it? Why do you hide it? That's my issue,
Yeah.
And they hide things. You hide that you have hypertension. You don't have to hide it. You can talk about it. Nobody's gonna hurt you. We can all work together to fix the problem. And then went on to say nearly 48% of African American women and 44% of African American men have some form of heart disease. So it's like, what can we do? How can we help? Why is it not getting better?
Right.
So what we're doing is talk.
Yeah. Thank you. And I appreciate that. And I just want to kind of add something. You just mentioned keeping it a secret, right? And before, as I was preparing for today, I thought about mentioning my family members, right? Here's an audience of people who don't know me, and I don't want them to assume that my family's not taking care of themselves. And there are other things that contribute to the way that the Black community is impacted more by these situations or these diseases. And I kind of want to move us forward to say, like, what are some of the cultural or societal factors, such as poverty and lack of access to things like healthcare, healthy food, and safe environments that impact the cardiovascular health of Black and African Americans?
Yeah, that's a loaded question.
It is a loaded question.
because what you just described is social determinants of health. Going back to my original statement, the Institute of Medicine mentioned that, at the underlying cause of all the health disparities affecting our communities and underrepresented communities in America today is social determinants of health. And what does that entail? It entails their income, their jobs, right? Generational wealth that has been incurred, cultural norms, the segregation that led to poverty in the past, civic engagement, violence, natural environments, right? Air quality, water quality, things like, housing, transportation, parks, recreation, safety, the quality of your public schools, implicit biases that exist, right? Access to quality care, and how do we define quality? Not just access to care. Cultural, linguistic information that's given, physician-patient concordance, in terms of, going to see a provider that understands your cultural norms as well. So these all lead, and affordability of care. Not to mention other things that are all in that list. So when you look at the whole gamut of social determinants of health, the only statement I'll make is that we have had this trend, and everyone here has mentioned a family member. Both my parents are diabetics, by the way. Hypertension, diabetes, heart disease, stroke, amputation rates, and dialysis rates. Do you know what they all have in common? In over 20 years, we have seen an upward trend of these disease states or conditions, what we call risk factors for cardiovascular disease, because it's a constellation of diseases now. It's not just the heart. We're talking about all these things that we call cardiovascular disease. We've seen a trend that is upward in 20 years, in spite of all the advancements we've made in our cath labs, in our pharmacies, in our pharmaceutical industry, and in our hospitals and in our outpatient sites, right? And telehealth. We've made all these advancements, but we haven't seen an improvement in the Black community or in underrepresented communities when it comes to all these risk factors. So what is the manifestation of not addressing social determinants of health? You'll see worsening amputation rates, which is a consequence of diabetes, worsening dialysis rates as a consequence of diabetes, worsening heart failure and stroke rates, a combination of diabetes and hypertension. Obesity rates are going up, right? 44 out of 5 Black Americans today are overweight or obese, which 50% will become a diabetic. The growth of this you're seeing now in younger population. The fastest growing diabetic population are actually young brown and Black kids.
Wow.
Right? So that 37 million that we're seeing that are diabetic today will lead to 60 million by the year 2050. And only 1 in 5 will know that they're diabetic. Only 4 in 5 will know they're pre-diabetic.
Sure.
None of them know the impact of what diabetes does because no one teaches it to them. No one knows what the impact of hypertension is or how to know your numbers early on. And so the manifestation of not addressing social determinants of health has led to this outcome. And what we're doing is, rather than having preventative upstream medicine, our healthcare system is designed to get the results it gets. It's a reactionary system. We react, right? Well, we're spending a lot of money, and who pays for this? Taxpayers.
Yes.
Everyone who works here. So this is generational scars and generational clinical, economical, and human impact of what you're seeing of not addressing social determinants of health.
Wow. Wow.
Can I just
yes.
add? And I'm just gonna say, in my area that I live in, every corner has a pizza shop, a Dunkin' Donuts, a Subway, a Chinese restaurant, like 3 Chinese restaurants. And no matter how you try to introduce a plant-based diet, fruits, vegetables, oh, I don't eat those things. And these are people like in their 50s. I understand teenagers are telling me, I don't want to eat a ripe banana. But when I have a 52-year-old and a 50-year-old telling me, I don't eat those things, I said, what are you doing? Are you eating for benefit or are you eating for taste? So what I usually do with these people, I sit them down and I Google and I said, let's read. Because sometimes they don't even know how to read.
Right.
It's a lot of ignorance. So you have to see the community that you're dealing with. I have Haitians, I have Jamaicans, I have Africans, I have Black Americans. They love the tasty food. That's the biggest problem. It's the food. And they were brought up a certain way and they don't want to change.
Yeah, I do.
I'm now modeling the way I want people to treat me. I model the way I want people to treat me. So if for my students, they will tell you, they cannot give me a bagel. If you want to give me something, you give me some fruits. And then we talk about the fruits. So I'm trying to make, I started telling people what to do, and I started to talk to me. So I find out when I start doing the right thing, people follow. But if you continue, like in my household, if you're telling people to, if I tell the kids, eat a fruit, my son will say, Mom, they're not listening to you anymore. Nobody's listening to you. So I start eating my fruits and I start eating my vegetables. They realize I'm looking a certain way, I'm feeling a certain way, then I see the changes. So you have to model your behaviors.
I definitely agree with that. And I think that's a great example. It's just, I think it's also something about lack of education. And I think we're going to touch on that a little bit later, because it's really like a lack of understanding of people can't interpret the information they receive. So, but before we go there, I kind of want to stay within the access and the lack of location. I just want to say something about the grocery stores. The grocery store near my house, the produce is old. Everything is like outdated. I mean, but when I look at the elderly people, they live in a building. That's the closest thing that they can get to, right? So that's access. That's all they have access to. This is all they can get to. And it's unfortunate. So it's also sometimes they might want to get something better. I actually work in New York City area, so I am able to go to the Trader Joe's, but my elderly grandmother is not able to get on a train and travel to the city and carry bags back home by herself. So that plays an important part as well. And I kind of want to say something about geographical location, because Dr. Facaretti, we had a really good discussion with you about urban areas versus rural areas, right? And living in the north and living in the south. And how does geographic location affect access to good care in this country?
Yeah, not all social determinants of health are created equal.
Yeah.
So, and it's not a one size model fits all. So what do I mean by that? When I grew up north and in New Jersey, for instance, even though there were, between Teaneck, New Jersey, Englewood, and West New York, right? If I wanted to transport myself, I can get on a bus, I can get on a shuttle, or, there are just things that can get me from point A to point B. In spite of my, my economic access. But when you move down south, and, I give an example between Memphis and Vicksburg, where I live, is Cleveland, Mississippi. For me to go to what you describe as a Trader Joe's or a healthy Whole Foods restaurant, you have to take an hour and 45-minute drive. So imagine what I just said. There are no public transportation modes, by the way. It's you either have a car or you don't. That's it.
Right.
There's no train, there's no taxi, that's it. There's no Uber. So and this is in a rural area where 40% of the hospitals are threatening to close. You're talking about predominantly African Americans, which is a consequence of, Mississippi being one of the wealthiest regions during slavery because of cotton. Cotton was huge here. It was a huge slave trade. The consequences of that, you have the demographic that's significantly Black, but also poor. It is the poorest state in the country with and what we consider a medical desert, but it's also a food insecure region, which is a food desert, right? Or people call it, it's just, you don't have nutritional access to food. But so what has happened historically, these people are poor. So what happens to the schools? The schools are not well funded, they're underfunded. Your taxes are not going to good schools as they'll go in the metropolitan suburban area. And then the educational system is not great. So when they come out, what kind of jobs are available to these folks, right? Not high paying jobs that come to this area. So you're not getting a lot of commercial insurance in this area, right? So you see where I'm going. And then generationally, the kids grow up and some of them are like, listen, we're out of here. Goodbye. We're moving to the metropolitan area. Or some are saying, hey, we're stuck. And when no one sits down and teaches them how to read labels, half of them which have a literacy level that's not high, right? And then not to mention a health literacy level that's not high. When things happen, such as diabetes or hypertension, and they've seen a grandmother who's gotten amputated, a mother who's gotten amputated because their sugar was never well taken care of, they didn't have access to care, or delays in treatments of care, or were not provided the best preventative strategies to preserve that limb. What you see is that these patients now have this mindset that it's okay to amputate my limb. But what they don't understand is 80% of them will die within 5 years.
Wow.
So generationally, all those things has led to an early death, where the life expectancy in a town that's predominantly Black, an hour from me, is 68 years old. And most of us in here growing up in third world country, we know that's a third world country number. Here in the United States, where life expectancy is in the 60s now, in some of our towns, that is sad. So that is a generational impact of how social determinants of health can it can live longer than one we think is just, hey, let's have a community impact, let's educate, and that's it. No, we need to address all those other factors and give them an opportunity to catch up, because those that are living in other areas where they have better educational resources, college degrees, their life expectancy are 15 years, 20 years higher than my folks who are living here. So I think that is an important aspect to also bring along as when we have this conversation, and when you target these communities in terms of strategies, you have to be intentional with that in mind.
Right. And I just want to stay here for a second, and I'm going to go back, check in with Dr. Malika and Dion in a second, but I just want to, you're talking about access and where you're at. Can you just please tell the story of why you opened the practice where you did?
Yeah,
Because I
sure.
know you're from Northern New Jersey and now you're in
Yeah,
Mississippi.
sure. I when I grew up in up north, I kept on hearing about Mississippi having the worst outcomes in all cardiovascular risk factors, and diabetes and obesity is our biggest challenge as healthcare providers because of the consequence impact, be it stroke, heart attack, or amputation rates. And especially with amputations, it's the fact that in this country, as a Black American, independently, you're 2 to 3 times higher to get an amputation versus a white American, even in the same socioeconomic status. 1, 2, the risk factors for an amputation are diabetes, nicotine use, patients who have high blood pressure, right? And people who have microvascular disease and chronic kidney disease. All 5 are more common in the Black population than in their white counterparts. So let's add that to that. They have the lowest access of vascular specialists and the lowest number of endocrinologists per capita. There are only 7 endocrinologists in the state that has ranked number 1 or number 2 in diabetes for the last 20 years. So what does that mean? It means that these patients have the worst health outcomes and also are not offered a limb-preserving strategy. 90% of which could be prevented if they are offered. So all these diagnostic and treatment algorithms are not offered to them. And so subsequently, they get amputated and they die early. So it leads to an early death. So I wanted to come here and start a practice. So I came here 7 years ago. We started into practice where we engage in the community, but we prevent amputations by providing upstream preventative strategies and procedures, and decreasing amputation rates by 88%, documented, and now serves as one of the national platforms for patients, providers, policymakers who want to learn how to really come to underrepresented communities and have significant impact from that standpoint. So their lives and livelihoods are preserved.
That's amazing. Thank you. Thank you for that. Thank you for the work that you do there. Dr. Malika, I just want to, anything, you guys are, well, you're located a little further north, I believe, in the New York area, not really within the city area. Could you describe like how that affects quality care where you're at?
Well, I think Dr. Fakaredi addressed a lot of it, and I thank you for addressing that, especially that you're living in the rural areas. But what I can touch upon, I mean, we live in a metropolitan area. And when you look at it, we have, in terms of when you look at the health disparities in terms of socioeconomic factors, education, we have it here within this area. But when you really dig deep down to what we have here, we have the same issues that are happening in the South and in the North. Like, for instance, in our marginalized communities here, I'm giving you an example, like in New York City, we've closed at least 11 community hospitals that these patients depended on these hospitals. This is where they could access their care. So what do they have to do? They have to probably travel further. We talked about access, transportation. These still even remain an issue in our marginalized communities. So I think more needs to be done to bring care to these people who need, because we all know, as far as cardiovascular disease is concerned, the quicker you get medical attention to cardiovascular disease, the better the outcomes. So if we're closing these institutions, where are we expecting to take our patients?
Right. Oh, really tragic. I'm
to her point. Can I say something to her point? To her point, there was a big study that came out from UPenn. His name is Alexander Fanaroff, a good friend of mine, and also doing good work in Pennsylvania. He looked at amputation rates in rural area versus metropolitan areas. Shockingly, a lot of the amputations that are occurring today are occurring in metropolitan area, but you'll be shocked as to where they're occurring. They're occurring in big cities, not far away from all your top hospitals. But there's the commonality they all have: a Black population or patients who have low socioeconomic status. So look, for example, if you look at where he is at UPenn, West Philly, large Black population, good Jamaican food, by the way, anyone wants to go there. Parents live in Philly, but amputation rates are high there, right? But let me look in New Jersey. North Jersey has some great hospitals, by the way.
Yes.
Between Teaneck, Englewood, West New York, I mean, you're talking about a true multicultural pot. The Dominican population is there, the Puerto Rican population is there, the West Indian population, the Black population. I mean, we have Asian population as well. But amputation rates actually, and some surrounding areas in New York. I mean, look at Columbia, New York Presbyterian Hospital in Columbia, huge Dominican population around. But people don't realize that the generational mistrust, there is still a mistrust in our community that both my colleagues have talked about, where we need to address, because as much as you provide them access, some people have generational scars that will prevent them from trusting the medical community. And that's where physician-patient concordance matters, where that you can facilitate care-seeking behavior, where they can come to us and come to you and say, you know what, these are my issues, these are my problems. Can you teach me and lead me to the promised land in terms of getting all the preventative upstream care that I should get before any bad outcome occurs?
Right. I'm going to deviate for a second, because you just said something about medical mistrust. And when I was talking to Nurse Dion, we actually talked about that a little bit, and how she builds trust with her patients and stuff. So would you like to elaborate on that, Dion, and your approach, and how you get your patients to trust you and you help educate them on their current state and the medication that they're using?
Okay, so I'm a nurse practitioner, and I do in-home assessment in patients' home. So on behalf of Fidelis and WellCare, they send out a nurse practitioner into the patient's home, and I do a yearly visit. And what I do is I go in, I do a non-invasive physical exam, and I also go over the medication. I do healthy eating habits. I do, I try to talk to them about exercise. And sometimes patients will say to me, this is the first time someone ever come to my home and actually talk to me and make it seem like they care. And I said, what does care mean to you? And they will tell me, you're sitting down and talking to me, asking me questions, and actually allowing me to ask you questions. So little things like, okay, what is this med that you're taking? Do you know why you're taking this med? I don't know. My doctor said I should take it. Do you know you have hypertension? No. What? You have hypertension? I said, yeah, it's on your chart. So on the chart, I have to write active, not active, or unknown. So most of the time I'm writing unknown, and sometimes I have to say to them, when was the last time your blood pressure was checked? I don't know. Okay. Do you have a blood pressure machine? No. Clearly they're taking blood pressure med, but they don't know what their blood pressure is. My doctor only said it was okay. So now I have to call the doctor, because here the blood pressure is like 190 over 100. And then they're saying to me, well, the last time she was here, he or she was here, they were supposed to call me back. But I said, but did you make the call? If the client is not calling you back, why aren't you calling them back? I said, look at what the blood pressure was. 190 over 100. Would you be okay with 190 over 100 for your family member? If it's somebody you care about? So right away, I try to fix it. I try to even send the patient to the doctor, or sometimes they don't have a ride to get to the doctor's office, because these are patients that's been utilized in the emergency room. Their doctors sometimes don't even know anything about them, because they don't have transportation. They don't have a family member that's looking over making sure that they're okay. So when I come in, sometimes I'm supposed to be there for 1 hour. Sometimes I'm taking a little bit longer, because I'm trying to see if I can fix the situation. Patients need people who can listen. And it's not just giving them med and rushing them out. You have to listen, and you have to find out, do they understand what you're saying? Sometimes they don't understand you. They just say, yep. So you have to find out what the educational background is. If you don't know the educational background, you can't be doing teaching with these patients. And
Right.
it's not going to take overnight. You have to do it in stages. And if you do things in stages and people see that you care, they will ask for you to come back again. They know when you care, and they love to see someone of your, if it's a black person, they want a black woman. Some of them are telling me, oh my God, I'm so glad that you're here. The last time they sent somebody in, she didn't care. When are you coming back to see me?
And I think that's very important. You do, I would say, I just had a recent experience with my brother. He was in medical care, and for me, I wanted someone that cared for him, right? I can tell the doctors and the nurses that did care for him and was really there to help him. And there were some there that just was doing their job because they were paid to do it. At that time, what can patients or caregivers experiencing health disparities do to advocate for themselves or advocate for their loved ones?
There's a lot that can be done. I think we need to go back to our training modules in medical schools and nursing schools and do a better job of teaching about compassionate care. We do more talking about technical competence, but we don't really hone in on the interpersonal competence. Like, when I meet a patient, it's, you want to, we say in the South, you want to love on the patient. You want to touch them, making sure that, hey, listen, I'm here. I'll touch your feet. I'll listen to your heart, give you a hug. You're going to be fine. Everything's going to be all right. Not the one that comes with a stethoscope, stands by the door and just, folds your arms. You can't do that. And that you see that, right? You can't do that. And two, so that provider patient communication is key, number one. Number two is what we call clinical but shared decision making. Whenever we speak to patients, the patient and I should have that plan and agree on that plan. Like, ma'am, I'm coming to take off your legs. Like, no, we are not doing that. Right? So that is not, it's not shared. Like, there has to be that discussion, or I will know what a second opinion is. So teaching our patients and like, hey, listen, there's something like second opinion. When you go to community events, you need to talk to them about the importance of not having some form of a decision in terms of your clinical outcomes, but also in terms of seeking a second opinion when you don't trust what was recommended to you. And addressing that generational mistrust will take time. I mean, for me, I think it took, because even though I'm Black, I grew up outside the Delta. And so it took about 3 years for them to really buy in, because they had to see that I was not a guy who was coming in for a year and leaving. I was part of the community and I was staying here. That is important, because they don't want the fly by night kind of folks who come in, get data and leave. Like, no, we want to see that you're part of us and that you really care for us, irrespective about social determinants. So that takes time. That can take years to crack that. But once you do, that word of mouth goes far ways. And then it's to let them know that, yes, and for those who are faith-based, when I go to faith-based events, I tell them, because they're like, well, I'm not going to claim it because God doesn't, God wants me to just, pray and everything will be fine. Well, I tell them that God brought providers to you too. He gave us the knowledge and the wisdom. So there's, there's this faith, there's the Holy Spirit, but also there's that physical and mental aspect that has to be taken care of. And that's why you have competent providers who have gone through similar situations with their family members who can help you understand better that condition and help you to a better outcome. And so those are the things that we have to discuss first, is that mistrust, address it, physician-patient communication, and also making sure that we do everything to take away biases and have shared decision-making in our plans.
Would you, anyone else would like to add to that? I think you all are great advocates, by the way. Just by getting to know you, you all continue to, not only do you do your work in your practice or your community in the hospital that you work in, but you also do community work, which is great. And I think that's what people need to see. And that's what patients want to feel, that there's someone not only showing up at the hospital, but they are in their community and they are available to talk to them. I want to move us I want to talk about, we were talking before about lack of understanding and education, right? What role do you think health literacy plays in all of this? So, and for anyone listening, don't know exactly what I'm saying, health literacy is the patient's ability to understand and use health content. And I think you all touched upon it a little bit, but can we elaborate a little bit more about that? And what can we do as healthcare marketers to help with that?
Yeah, you have to understand the community you serve or your community you're targeting. If it's a Black community, health literacy matters because, you know, there's this notion that what is applicable in Boston is applicable in Memphis, Tennessee, is applicable in Los Angeles, and it's applicable in Mexico or applicable in Scotland, you know, in Chandler, Arizona. No, it's not. Different demographics, different patient populations, the geographical issues, cultural issues, and norms. So meeting patients where they are to kind of understand what the gaps are, what the strengths are in that community, then taking that information and then creating your messaging, not making your messaging and saying, okay, where can I make this work?
Right.
Right. That's usually the strategy with industry. That's why they fail. I tell every industry here, if my patients have not been spoken to before you create your device or your pharmaceutical medicine hasn't been tried in that patient population, then you failed initially, because these are the patients that actually are affected, you know, when it comes to maternal health, for instance, and complications.
Yes.
A lot of people just do not understand, especially in the Black community, that any kind of natal or any pregnancy complication, particularly things like hypertension, preeclampsia, and other complications, put them at increased risk for a stroke or death, at 2 to 4-fold higher than their white counterparts. I mean, it's a risk factor, cardiovascular risk factor. Well, I need to go and explain that at the level of what my patients understand, not give them a pamphlet or a note. Like, you know, my patients are visual, and you speak it in terms where they understand, and the messenger also has to be someone that they find relatable. Those are the things that to me matter from just a one-on-one standpoint. And my colleagues can add to that.
Yeah. Would you, Dr. Malika, would you like to add to that?
I do agree with what Dr. Fakoredi is saying. And in addition to that, it's just not your patient per se, but the family unit. Like, for instance, if you're addressing cardiovascular disease, then you ask yourself, who does the cooking in the house? Bring that person to. Who does the buying of the groceries? Bring that person to. So you're just not educating a single patient population, but more of a community where they're all at risk for these risk factors. And you tell them you can't eat these foods. And it's not a matter of saying you can, but we have to give them also realistic goals that they can live their life. But it's the amount of, it's in moderation. What does moderation mean? So as we talk about our patient population and health literacy, I can tell you sometimes with my diabetics, I use the palm of my hand. So I tell them, if you're going to eat rice, it's pretty much so they can visually see it, the palm of your hand, and that much. So I tell them 3 tablespoons, that's your serving. The rest is either your protein and your vegetables. So it is relatable, no matter, I don't assume, like, for instance, if you're highly educated, you won't understand this, but we can see that these risk factors are across the board. It does not matter the socioeconomic status. We're equally affected with these diseases. So I like to engage in terms of when I'm educating my patient, it's just not the patient, but everybody involved, especially if they're there at the bedside. That's the best time. And I go around and said, okay, did you understand? What are we going to start doing? And the key thing is in terms of like pretty much addressing the obesity rate, exercise, activity. And I tell them, I don't want big increments. I just want small increments, small things at a time, and we will get there.
Right. Very important. And I can't stress that enough, the lack of education. And that's what we kind of do here in our industry, right? We're healthcare marketers, but you all pointed out a great point. You need to know the population really well, right?
Absolutely.
You need to be in the weeds with them and, you know, understand the population and who you're dealing with, not trying to come in from the outside and try to pierce the market, but really know deep down inside what this community is dealing with. And that is something that's very important. I want to just go, I had a lot to talk about today, but you guys are so great. We're gonna try to bring it back. I'm gonna ask some more important questions and then I'll see if I can go back to some other questions I plan to ask you today. I want to also talk about, and you guys, again, everything you're kind of touching on. So how important is preventive care when it comes to cardiovascular disease? And what would you recommend? What type of preventive care would you recommend that anyone do to help prevent? You know, I know someone mentioned that Dion, your daughter is 20 years old, suffering from hypertension. How can we get ahead of that?
My daughter.
I'm sorry.
Not my daughter, a friend of mine, her daughter.
Oh, a friend of your daughter.
She has hypertension.
Okay.
Yeah. And, you know, what I can say, preventive care, it's less, I would say less drama. When you do have a dialysis, say, if you don't take your hypertension and you end up on dialysis, you're looking for more problems. Hypertension, yearly checkup, exercising, eating right. And when I say eating, you have to tell people what they need to eat. It's not just saying low sodium. What is low sodium? If I'm going to tell you, don't eat that, put that salt in your food, I am going to tell you what would be my recommendation of what you should be having. If I tell you to have fruits, I'm going to tell you the benefit of eating the fruits. If I tell you to have vegetables, I will tell you. What about sleep? A lot of us are not sleeping. We work too much. So we work, right? And we don't sleep, and then we end up with the hypertension, and then we get more problem. And by the time we look around, hypertension is a silent killer. We're gone. All we're getting is phone calls saying, hey, did you know so-and-so died? I said, really? What did they die from? She had a long-standing hypertension. So again, preventative meeting, getting up, 30 minutes, exercising. I'm talking to myself as well. Sleeping 8 hours. I'm talking to myself as well, because I'm not a skinny girl, right? So if I'm going to tell my clients to exercise, then I need to talk to myself first. So you need to set the example. So for me, I've been eating right. I haven't been starting exercising, but I lost 20 pounds. So that I can tell my clients when I go in and say, hey, this is what I've been doing. And they love to hear real life story. They don't want to hear stuff that's happening in another neighborhood. They love to hear, oh, you had weight on, you were much bigger, and I'll show them a before picture of me. And now they see an after post. They're like, oh, wow, you really look good. Now I can smile more because I'm taking better care of myself. So if I'm taking better care of myself, I can talk to my clients better. But if I'm keep having more weight, what does my client think about me? You tell me what they're going to say when they see a woman that's not taking care of themselves. As soon as I leave, they're going to say, why is she talking to me when she can't even take care of herself? So you have to set an example of patience and for your family in order for people to listen. They will follow you if you're doing the right things.
Right.
Yeah, Dion makes a great point, and congratulations, by the way. To her point, the number one preventable cause of death, cardiovascular, from a cardiovascular standpoint is your diet and your exercise.
Mhm.
That's number one. It's not any medicine. It's, we always say, what you eat is
Yes.
medicine. But diet and exercise are number one, combined. And so that she's highlighted. The second thing is to make sure that, from a health literacy standpoint, there's something that I want to mention. Nicotine use. No, you notice I don't say smoking. So when I was up north and through all my studies in med school, we used the word smoking, right? Smoking tobacco. Then I moved down south, and a lot of my patients are elderly Black women. And a lot of them were having cardiovascular outcomes like, poor circulation. And I'm like, wait, I asked them, do you smoke? And they told me no. But then when a family member, to your point, Dr. Malika, they come into the room and they're like, well, she doesn't smoke, but she dips and she chews. And you're like, whoa. How long have you been doing this? Since I was 8, 9, 10 years old. Because it's common, like when they're with their grandmothers, are dipping, they're dipping nicotine. And so that builds up, plaque buildup in their arteries. And so that is another important thing that I stress out, that, you need to elicit information. And especially when you're putting together content, you want to make sure that is relatable too, in terms of identifying who's truly at risk. Don't just put smoking, because most people here who don't smoke but are dip and chew are actually affected significantly from such outcomes. So just wanted to add that in addition to all the great things that she mentioned. And lastly is that women need to take better care of themselves. They'll take care of the family, the dog, the husband, everyone, the church,
So
before they
true.
take care of themselves. That's why really, it's Heart Health Month, but it's also, women need to do a better job, because they're going to be ignored when it comes to that emergency room visit.
It's true.
Your symptoms are ignored. So let's try and be preventative and take better care of ourselves.
True.
So I always advocate that women need to not, take your symptoms seriously. Don't wait for that chest pain. If it's dyspnea, which is shortness of breath, or if you're feeling that you're having some form of fatigue, or you're feeling that you're having GI symptoms, or that back pain or lightheadedness, it can be a cardiovascular event. So take it seriously and get checked out. And don't let an ER doctor tell you that it's just stress.
Thank you for that. I'm like, I feel like I felt all of those symptoms before, but I just had my checkup. I'm like, so everything came out great, but that's good to know. So we have about 10 minutes left, and you guys kind of touched on everything. So we're getting close to the close. So I'll give you all a few minutes to wrap up, and just, can you tell us one thing that you do to take care of your cardiovascular health? And I'll start with Dr. Malika.
Yeah. Okay, so as I said, my mom has hypertension and diabetes. My dad had heart disease. So you can think about it just from the family history. The risk factors are there. Being African-American, I am hypertensive. And when I tell people I'm hypertensive, they shake their heads. But it is there. And as I said, it is a silent killer. And Dr. Fakorede, as you said it, it's very true. I'm a mom. I'm shuffling. I'm taking care of everyone. I'm taking care of my mom, my husband, my children, and my family. And I remember going to a doctor, and he was my fellow colleague. And he looks at me and goes, Malika, what are you going to do with that blood pressure? I looked at the machine and I said, you must be kidding. That's not my blood pressure. He goes, well, you were sitting there, right? And immediately I called my colleagues who are cardiologists, and I did the workup and what have you. And I realized I had to accept that I do have the risk factors. Yes, I do have it. And despite doing everything that I think I did right, like I am always very active. Whoever knows me knows I'm very active. I try to at least jog and exercise 3 to 4 times a week. I've decided most of the times, anybody who knows me, I cook all my food from scratch. I buy my own ingredients. I control my ingredients. I know salt is not something that goes very well with my ethnicity. So I control that as well. So one of the things that I do really do is keep staying active. When we talk about eating right, I mean, sometimes I indulge, but it's also eating the right amount, the right portions in moderation. And then try to balance it with the fruits and vegetables. And I try to rest as much as I can, Dion. Some nights, if I have 6 hours, it's a good night. Sometimes it's not. And I try to avoid stress, but working in the environment that I work in, there are days that I can say, okay, it is stressful. And I just have to remind myself, it's not the end of the world. this day shall come to an end and I'll have a better day. So that's how I take care of myself. Thank you.
Thank you. And Dr. Felicia Faccaretti. I just want to say your name because I've been working on it all week, and I'm happy that I have
it. You get an A+. Yeah, for me, it's just 24 years now dedicated in terms of going to the gym and exercising and getting on the treadmill and getting things, just being disruptive in how I exercise. I think that's good. It's good to change your workouts here and there. So that has kept me disciplined. I maintain that discipline from that standpoint. What I eat is very important, but being the CEO and taking care of all these patients, I have about close to 10,000 patients and 42 employees. Stress can come in. So I think for me, actually, one thing that we need to actually add to the list is compassionate care. When you give it out, you feel it. You feel like there's more to your life, your legacy, and you're happier. And for me, that's very important. So it's not, and how I utilize that passion is to go and talk about targeted health policy and public policies that will benefit my community. And for me, those are needed to address inequities in care. And so it's gone from pivoting from the personal to how now it influences all, while we have that dietary modification and exercise adherence. So for me, that's it. And prayer, thanking God for every day we live, another day.
Yeah. So and last but not least, Nurse Dion, and just to keep you on track, we have about 5 minutes. I want people to get your information, and that way they can hear everything you have to say.
Well, number one, you need to be connected with God. That's a number one thing. Number two, sunlight. I haven't heard anything about sunlight. 50 minutes in the sun will do the trick. Yes. Exercise 30 minutes per day, 7 days a week. And my doctor said, Dion, it's not running around on the unit. We're talking about brisk walking. So again, I'm working on that. I'm working on getting more sleep. I used to work 4 or 5 nights per week, 12 hours. I'm down to 2 nights per week. I'm hoping that will change. And I'm staying away from stress. I'm sorry, but a lot of stressful people are around. They'll stress you out, and I am staying away from them. And that's my story. That's my story.
I love your story. So I just want to say, as I prepared for this, just because I knew I was speaking to an amazing panel, I went to get my checkup. Everything is great. My LDL was still a little high, but I'm working on that. But thank you. I am definitely incorporating eating better, getting better rest. And one thing I'm not doing, but I plan on doing, and thanks to all of you, and your recommendation is definitely working out and being more active. I know I'm a city girl, and I try to stay I'm active by taking the train and going back and forth, but I'm going to commit myself to daily exercising and doing establishing a routine. But we're coming to an end, and I just want to thank each and every one of you for joining us today. It's been a pleasure to get to know you all. I feel very welcome to sit here with you all today and moderate this discussion. And I hope that we continue to keep in touch with each other. And thank you. And to everyone listening, thank you for joining this episode of Black Health Now. And I hope you tune in to next month's episode. Thank you all.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank